Good morning, dear students. Today we'll be learning about a very important concept, and that has to be clear in our minds. So, to start with, I have an image for you. So, what do you see in this image? That we need to look at it. See what happens. Can you reach to a point that what is happening here and why this person is behaving like that? Is he having a problem? Do you think he need your attention? Think about it. So, yes, this person was having a problem while he was walking. He was kind of limping. And this is a problem. This problem is with his walking style. And this, we call it as the gait. So now, let's look into that. Let's look into the structures which are involved. We have talked about the gluteal muscles, and we have covered in the gluteal region on the back of my thigh. In the gluteal region, on top of it, under the skin, we have gluteus maximus. And under cover of gluteus maximus, we have gluteus medius and gluteus minimus muscle. These muscles, primarily, they are controlling. They have so many functions, but their primary function is they are one of the strong abductors of what? Abductors of my hip joint. Now, so they are abductors of the femur at the hip, and then they are doing a big job. They are stabilizer of pelvis on a stance side. Now I hope everybody should understand what is stance side, because my first presentation about MSK, about lower limb, there I was talking about the gait cycle. So the stance, so during the stance time, and it prevents it from dropping on opposite side. So unsupported swing side. And the other action, so they are the abductors, and they rotate the thigh medially, and they stabilizes the pelvis on a stance side. So when we are taking step, at that time they come in play. So now superior gluteal nerve is the nerve which is there to innervate these muscles. So if someone has an injury to superior gluteal nerve or other factors, so the actions, and what is the main action? We talk about it. They are the abductors of the femur at the hip joint. So that will be affected. So now, what are the different conditions? When these actions has been compromised, we have an injury to the nerve. We have dislocation of the hip, so there might be an injury occurring to this nerve. Some surgery, some accidental injury, a disease called poliomyelitis. Poliomyelitis, we talk about that. This affects the motor neurons, motor things, motor activity. Those have been affected. So injury in any form, and then this results in what? It results in muscle weakness, and this muscle weakness will result in loss of hip abduction. So once we have this, these are the various functions performed by this muscle. And now, it could be there is a partial tear due to a trauma, due to an reason, or there is a complete disruption. You can see that partial tear, and you can see that complete disruption from the distal attachment from this femur. So these are the factors. Now, look at this person. She is standing fine. There is no issue. And look at the whole of the pelvis, the two innominate or the coxal bones, upper end of the femur, and the gluteus medius, and many muscles underneath, so you cannot see that. So they are visible to you. So now, going further, so this is a normal neutral standing position. Now this is how, when we abduct our femur at the hip joint, so this is what we do. And you can see that when I'm standing like that, my body stay erect. This muscle contracts. So the whole body weight and this muscle, these two muscles are responsible in making the body erect. This muscle, this whole limb is in the air. So the weight is being transmitted, and these muscles are supporting, and they are not allowing that this pelvis to be sinking downwards. Right? Look at this. If you compare from the previous image, you can see that this is up in the air, and but the body is staying straight. Now, these muscles, these fibers, they're contracting and they're keeping everything intact. But if, as we said, if we have some kind of injury due to any reason, so now when this will become weak, so this will not be able to perform its function. The primary function we talk about, abduction, and then it was also preventing the sinking. So now look at it. A normal person while walking, look, this foot is on the floor and this is in the air, but the pelvis position is staying at normal. So it's all fine no matter somebody is walking. Now look at it, how these people present. But if you compare this image with the previous image, so when this person is walking, this line is not straight because these muscles are diseased, these muscles are affected, and they are not pulling it, they are not contracting it, they are not making the position. So that's why the person is tilting the body, so to keep himself or herself in a straight posture, but there is a bend, there is an extra thing because these muscles fail to do what they're supposed to do. This muscle, this leg is in the air, and so this is, but this, the normally this was contracting, so this was keeping the whole thing erect, but that is not happening. So now this is how it is, this is a presentation. So this side, this muscle is not working, and then there we have what, dipping of the pelvis is being dipped, and this is, we call it as a clinical term, Trendelenburg sign. This is a classic term. This type of walking which you have seen is called lurching gait. And now as a result of this, so person is trying to tilt the body to give a balance, but the body will not stay straight. This foot is in the air, this leg is in the air, this muscle is not responding, so the person is trying to tilt the whole body on this direction where we have the lesion. So the body will not stay straight. And that is the Trendelenburg sign that we need to be clear about. And who's losing its function? Either the superior gluteal nerve or the gluteus medius and minimus, both. Now, look at him, the person, real person, we saw him walking. Now, if anybody who you are suspecting that has a problem in his walking, when he visit to your clinic, ask the person to stand on one leg, one by one. And if the person, look at the posture of the person. If person maintain this posture, it means it's all fine. The glutei, medius and minimus, they are fine. But if we ask the person to do so, and the body, you can see the change, the tilt on the other side, so that means there is a problem with these gluteus medius and minimus muscle or their nerve. And that is, we can label this person as that person is having Trendelenburg sign, and that is important, and we need to correct it because socially it's unacceptable. You see somebody when he or she is walking, is limping, they have difficulty in running, they have so many social problems, so that need to be addressed at. Let's see this cartoon, and there you can see a normal person standing. Even this is when the both legs are on the foot, same level. One leg is in air, but still this muscle is fine, so there's not happening. The person stays the way it has to be. But if this is paralyzed, now as a result of that, the body will go tilted. Body cannot maintain this erect posture, so the body will showing a tilt, and that will be visualized like that. So by definition, Trendelenburg sign is when the gluteus medius and minimus of one side are paralyzed due to injury of the superior gluteal nerve. The pelvis sags on the healthy side if that foot is off the ground. As a result, the person walks with a lurching gait. So this gait is called lurching gait, and clinically we call it as Trendelenburg sign. I hope after having this session you have understood this term, and if it's been ever been used, or if you see somebody walking like that, you should be able to diagnose him as this person is having a lurching gait, and is basically, or in other words, in clinical terms, you can say Trendelenburg sign. It's not like, oh, he's limping, but now you know a scientific answer. I hope this description will make you understand this concept. Thank you very much.